Hi, I'm Dr. Snehal Gadhecha, neonatal and pediatric physiotherapist and certified early intervention specialist. The purpose of this case presentation is to emphasize the importance of early diagnosis and intervention in a high-risk premature infant. Infant X is a 17 months corrected age male preterm child born at 23 weeks. He was extremely preterm with an extremely low birth weight of 570 grams. His head circumference was 22 cm. He cried immediately after birth. He was admitted in the NICU for 90 days for respiratory distress syndrome, neonatal hyperbilirubinemia, early onset sepsis, neonatal seizures, chronic lung disease, extrauterine growth retardation and bilateral grade 3 IVH. We assessed the child in the NICU and used standardized motor assessment such as general movements assessment. GMs showed poor repertoire followed by absent fidgety movements plus an asymmetry in segmental movements in the left upper extremity and left lower extremity, which indicated high risk for hemiplegic cerebral palsy. His neurological assessment Hine scores indicated high risk for cerebral palsy, and his developmental assessment on Bayley's showed at risk for gross motor development. These assessments allowed us to accurately diagnose a high-risk preterm infant, intervene early in his development and educate the family the importance of early intervention. In early intervention, we encourage family participation to facilitate success within the child's environment. We focus on family coaching and parent training. The early intervention for this child was started from the NICU. We used evidence-based treatment approaches such as early intervention using both the principles of Bobath and neurodevelopmental therapy. This was used to promote flexor tone, symmetry in head alignment and midlines. After the child graduated from the NICU, early intervention was started to achieve age-appropriate milestones and prevent asymmetry. Gross motor and fine motor skills were worked on to facilitate head control and trunk control in all transitions, bilateral motor coordination, constructive and intentional play, and reduce asymmetry. Along with this, we also used complementary therapy techniques such as ProPhysio, ankle foot orthosis and kinesiotaping for optimal alignment. With the help of intensive therapy and the dedication of the family to follow home intervention, the child is now able to independently roll, perform supine to sit, perform all transitions in sitting, crawling on hands and feet, kneeling to half kneeling, pulls to stand, supported standing and cruising, and there is also emergence of independent standing and walking. In fine motor, bilateral motor coordination is present and left hand has controlled reach and grasp in all planes of motion. It was through early intervention we could maximize this child's functional independence and reduce the risk of developmental delay.